Welcome to the March 2015 Medication Management Update with John Karwoski, President and Founder of JDJ Consulting. I'm Brittany Lodato, the Administrative Director at JDJ. Audio from this video was taken on March 17th during an educational session with USPI nurse managers, administrators, and executive staff members. The audio has been edited for time and best quality and was paired with the slides after recording. During this video, John will address emergency carts such as crash carts and MH carts, recalls and shortages, aspirations in the ASC, drug disposal, FDA unapproved drugs, how to manage critical drug shortages, shopping for a compounder, and finally, benchmarking studies conducted by JDJ Consulting. Enjoy the video.
From a basic standpoint, we get a lot of calls. What should be in our code card? What do we carry? We have all these drugs. Are they needed? Well, unfortunately, no one has come out nationally as with a list that this is what you need to carry in an emergency supports part. We're going to talk a little bit about that. But N-House otherwise has an approved malignant hypothermia cart contents, which is really nice for us to adopt and follow because now you have a standard list of supplies and drugs. They just made an update this year to that list, and you might want to take a look at that. But your crash cart is something that over time should be reviewed, and again, that's another annual thing that you want to take a look at with your medical staff, your nurses. Has ACLS changed? Has anything changed with response to emergencies? It's something that we never really want to have to open for an emergency. I mean, that's there to protect us, but it's the safety net that we want to have in our facility. And recently, we recommended adding aspirin, small bottle baby aspirin to the crash cart. I get the same response. Oh, we have it in our PACU cabinet. Well, what happened in one facility recently was a patient in PACU had chest pain. Anesthesia told the nurse to have them chew aspirin right away because it can be that first line of prevention if it was cardiac-related chest pain. And they went to the cabinet. Somebody had used the last of the aspirin in the facility, had no aspirin in the building. Now, I had a friend who recently retired. He's in his 70s. He was down in his summer house down the shore, and he collapsed. His wife said, he was a nurse, grabbed his hand, had no strength. He was having a stroke. He chewed aspirin. They immediately got him to the hospital. He had TPA within 2 hours, and he has no residuals from the stroke that he had. So aspirin's an important drug, and I think that's what your crash cart is designed for. Those moments when you know something needs to be happening quickly, and you know the crash cart's checked monthly, it's in date, if something's not available, we discuss it, and we reorder it. Recalls, something to write down is who tracks your recalls, and you want to make sure you keep the documents that pertain to your formulary. There are many, many recalls that don't pertain to us, so there's a process of going through those documents, but you want to make sure, if asked, you have that information on one file. Shortages, where do I start with shortages? It is a very nightmarish time for us in the industry. There's many reasons for shortages. I'm not going to spend time with it because I might have a few slides on that in a second, but you know, that's something when I walk into a facility, I'm looking at all the areas where meds are stored. Are they organized? Are they clean? Are they labeled nicely? Do you have a sound-alike, look-alike list? Okay, your accrediting agencies want to see your specific look-alike, sound-alike list. That's not the list from ISMP that you print off 2 or 3 pages of 100 drugs. It's taking that and saying, what do I carry that we should have posted that we might mix up in our facility? It may be 4 or 5 drugs that are look-alike, sound-alike to your facility. It might be 10 or 15. And that's something that you want to design for your specific ASC and the drugs that you carry. High alert is the second part of this safety net. High alert drugs, if you go to the Institute of Safe Medicine Practice, they have about 20 classes of medications that have a narrow therapeutic index that can be dangerous if administered incorrectly. So you want to look at what you carry off of that high alert list and put in safety measures for preventing errors. Okay, let's talk about insulin. We had a surveyor want to make sure insulin was on the high alert list because insulin was on that list. What do we want to do with insulin? Well, a lot of places will put in place a second visual check prior to administration. It's not given a lot. There's a risk of maybe drawing it up incorrectly because the minute units that we're going to be preparing. So a second visual check can guarantee that if the doctor ordered 10 units of regular, that's what I have here. Go ahead and give it. Heparin's another high alert drug. I don't know if too many people have heparin, but you want to be careful on how you stock and store and administer heparin. Let's keep it in one location, and when that surgeon is scheduled for that surgery that day, a vial is released for that case, and that's it. It's not in every part. It's not at risk of being mixed up with another drug, because that's one of the dangers of having is to have a mistake with one of these high alert drugs. You know, I think that we always come up with different tools for facilities. This is a nice chart that we came up with for patients that are allergic to penicillin, allowing the nurse to know this is red. These antibiotics are definitely can't be administered if the patient has a penicillin allergy. These may be possible. It's a discussion with the surgeon, and these are good to go because it's a green light. They're safe that that antibiotic is given. Penicillin has a lot of interesting debate recently. How much cost sensitivity is there to answer? Very minimal. You know, I'm trying to get the most recent articles about cost sensitivity. They talk about 5 to 10%. Now people are saying even less than that. Unless it's true anaphylaxis to a penicillin agent, that you don't have a possibility of crossing over to the cephalosporin. But we're going to continue to try to put new drugs out when we see information that would be helpful with the nurses in that area. Any questions on the basics of medication management?
Xylitol.
Yes.
We use it for GI a lot, okay? And it's not an IV drug. How do we manage that with no watch?
Well, there are no regulations at the FDA or state or federal on any non-injectable medication shown by the book after. Your facility may elect to have a policy that oral medications are open for 6 months or for a year or one-time use, whatever you decide.
28 days, and you're going to label it. And
there is no requirement right now to have an expiration date on oral meds. The only requirement at the FDA level and the CDC and CMS is injectable drugs. If a surveyor wanted you to change that, I would request that they show you the document in the federal rules or state rules affecting those types of medications, because the FDA has not come out with a position paper on anything other than injectable drugs. So nurses can administer medicines out of the original container upon a physician's order. Once you start moving these things around, that's either repackaging or compounding, where you get into a lot of regulations that you don't want to have to deal with. So really, a couple topics here that are new to some of you, and maybe you've heard of before, is we're going to proceed and see how far we go with some of these. Something that came up a couple weeks ago is I had an endoscopy center look at their aspiration, and they looked at the charts of these patients, and they realized one commonality was that patients, all the patients that had aspiration in that year were also taking these antidepressant, antipsychotic medications at home. We thought that that was interesting enough to say, if you're doing endoscopies at your center and you had aspiration and you wanted to look at those charts, let us know if that's something that is common with your patients. Drug disposal is a common thing going on right now. How do we get rid of medications? We have changes that have to take place. Hospitals have already implemented a lot of change for drug disposal. Now, in the past, we've heard many things where, the red sharps would be a place to throw the empty, the partially filled vials, the partially used syringes. Some places were actually shooting them out And then we had the chucks and the shooting them in chucks and throwing the empty syringe out and the empty vials. Some were just throwing partial syringes and partial vials out in the red sharps. We have to change this now. The red sharps is only going to be allowed for empty sharps, syringes with a needle on them. I don't think we should be taking off the needle because that's something that is risky. But if it's an empty syringe with a needle, it's in the red sharps. Okay. What's going to happen with the medications that a doctor has in a syringe after a procedure? You have a vial of a medication that you may have on the back counter. Okay. The new area for this type of disposal is, and manufacturing and drug disposal companies are implementing this, is a different colored bucket with a different colored lid or a different type of container that allows you to throw these partial syringes, partial vials, not emptied out, but just right in this container that goes for incineration. Okay? The syringe, which has partial medicine in, and the vial, which has partial medicine, is all supposed to go into that white bucket, because we just had a center get cited for shooting out liquid into this container, because then that could be, spilled or something like that.
And that is per, I have to call Stericycle.
Yeah.
Yes, Stericycle is completely,
Oh, they're so confused.
they're very
They are very
confused.
confused.
Really, they're all over the place.
Yeah.
First they said to put a solidifier in it, then
Right.
they said, no, don't put a solidifier in it because there's nothing in the
Just the paper
guidelines.
towels or something in there,
Right.
absorb. They want us to shoot it out into the black container, then take the syringe and put it over there. Of course, my docs are too lazy, they put it in there, so then.
And whatever system is implemented, we find that no one knows where to throw things and how to throw things, and it gets lost.
The main thing that you have to remember is that according to DEA, they have clarified that the only correct method for disposal of controlled substances is now incineration. So you need to just make sure that these partial vials or the partial syringes are going into a container, which is their end result is going to be incineration, whether it's Stericycle or Daniels or another disposal company. And you'll have to clarify with them which bin to put it in, but directly from the DEA, they have said do not shoot. They don't want to see the shooting of the liquid out because then it could always be potentially retrieved, especially if you turn that container sideways.
It can be retrieved by reaching in.
Yeah,
Somebody
reaching
wants to
in,
get
yeah.
it,
The clinical director was running around taking those vials out of there and using them on personal, obviously had an issue.
The drug disposal companies are saying that their products that are meant for this kind of disposal specifically, their response is that you can't fit your hand into the opening.
You could put a hemostat in there and that's exactly what he was doing.
Yeah.
And we do have a lot of gray in this, and different organizations trying to figure out what to do. One company's name is Daniels, but this has, when you drop that partially used syringe with fluid in it, whether it's a narcotic or a non-narcotic, or a partial vial that has no access beyond this mail slot, and that's picked up by the company and incinerated. So with this type of container, you're absolutely right. When it's a narcotic, we don't want to have anyone being able to access this. And the DEA said it must be unretrievable. That's the definition. The word is non-retrievable, and that's why incineration is going to be taking this container and incinerating it.
Does the needles go in this? Yeah.
Yes.
Okay.
Yes.
Everything.
Yes.
And it comes that way, or it comes like, it looks like a bottleneck. You flip it in and you can't go in there. Now, if I was looking for something that I wanted to retrieve, I can go through the back, there's a key that's associated with it, so in case I needed to open it.
Yes. The red does not get incinerated. The red gets autoclaved. And these drugs have to be incinerated that are not used any longer. The DEA requires that for controlled substances and non-controls also. So the only thing in the red sharps now is an empty syringe and needle and an empty glass vial. So you really want to look at the company, Stericycle is providing this service. Daniels is another company that we've had a few accounts signed on in the Philadelphia area. This container handles the partial syringes and partial vials of medication after procedures. This does not accept them any longer. This must be for the empty syringe and the empty glass vial. So anything partial gets thrown in here, and this container, you want to ask the question of the company you're using, can anything be retrievable, even with a hemostat? Is it impenetrable, meaning no one can get in at that? Because we are a fear of those partially used narcotics after a procedure. And I always felt that as a consultant pharmacist, I wanted to see someone shooting that syringe out in the red sharps, because then you can't just take the vial out of the parts. Even propofol, you know, we used to see those partial propofol vials in those red sharps, which was, I felt, dangerous. So this is going to take the place of that, and this is something that we can't get into. And then that gets incinerated. So staying within that realm of the operating room or at the bedside where you're using a vial, is there questions that you can think of that we haven't discussed? Brittany and I are attempting to come up with some type of educational poster that can show someone's hand throwing in a syringe with some liquid in it, and then that would go into this container. Or a vial with the liquid in it after procedure that would go into your white container with a purple lid or whatever. It's not accessible. Then we're going to have a picture of the empty syringe and the empty glass vial going into the red sharps. The only area that we didn't touch on was the hazardous medications. We do not handle a lot of hazardous medications in the ASC industry. But we really want you to know, if you have any, what they are, because that will then go into a different color, usually a black bucket for hazard, or the company may have a different category color. I'm not going to talk about colors because companies may vary that, but it's the hazardous waste that you have to determine in your facility what they are. Inhalers, patches, the transdermal nitro patch. If you have silver nitrate, you also in tablets, but you don't have that in your centers. So hazardous is a category all its own. When we get a disposal company in, Stericycle, they're going to look at your formulary. They're going to identify the hazardous meds. And then that's what you'll be able to post at that black bucket. You may have one black bin that's called hazardous in your building that may last a year, and they pick it up once a year. Because the cost comes when they have to be called to remove one of these containers, okay? And depending on how fast it fills up, the savings can be dramatic if you don't need it that often. But you'll need a hazardous bin. This is the bin that I think is the education part now. It's this non-hazardous, partial vial, partial syringe container that will get incinerated. It can be narcotic, non-narcotic. Okay? All of that's going to go into non-hazardous bin. It should not be accessible by anyone. According to companies that we've been talking to, like Daniels or Stericycle, now Stericycle I don't know because they're sending mixed messages, but the partial syringe and partial vial go immediately into this with no need to expire what's left in the syringe. Now when that gets filled up, that call is made, a company comes in, takes that, and incinerates that. Okay? Now let's talk about expired meds. Who has experience with reverse distributors? The reverse distributor is set up to take away a box or a bin or a bucket of expired meds, and they charge you a fee every time they come out. Maybe that fee's associated with your credit. Maybe they take the money off your credit. No longer are we drawing these drugs out of vials and shooting them anywhere. They must be removed from your facility. So that's another big change in our ASC industry, is that some facilities were, they had expired meds, drawing them up, shooting them out, and throwing the empty vials in the trash, or wherever. Expired drugs, if you don't have a lot, the whole vial can go in this type of white bucket. Again, non-hazardous drug removal. Now this, again, they're paying you for the weight, so we have to consider costs. Again, they can be costly. I had a facility, a small multi-specialty center down in Vineland. She spent $1,500 last year with pharma logistics. And she can't figure out, to take expired drugs away, $1,500. So we need to evaluate the costs associated with this service. Now, how about expired narcotics? Reverse distributors will take them also. Okay? That it would be a fee. In New Jersey, we do have a CDS department. Question still to be answered is the state CDS acceptable for us to destroy narcotics? If we have that permission to destroy them, how do we destroy them? We're in the process of trying to figure out if that is still acceptable, because Brittany and I just listened to a webinar on the changes with the DEA drug destruction, and they are saying that all expired narcotics must be incinerated, and that it must be done by a reverse distributor or a take-back pharmacy. Okay? Now, we just met with the owner of Divine's Pharmacy in New Jersey. Robert is the owner for 37 years. He has signed up to be a take-back pharmacy, which can hopefully remove your expired narcotics, and he can incinerate them. But we have to wait because he's going through the paperwork with the regulatory people now and getting approvals to do that. You might pay less throwing them out in there than you would using a reverse distributor. So I want all of you to think about your costs associated with your current reverse distributor if you're using one. How is the fee set up? Maybe call another one. We made a call to
Reliable Returns.
Reliable Returns, which is also on the list. There's another company, EXP, that has gained momentum in discussions. But I would think that you want to call a competitor and say, what is your fee structure for removing expired drugs, expired narcotics? Reliable is the same price no matter it's 16-pound bucket or a box.
15 pounds, I think they said $150. It's an additional $2 a pound, something in that neighborhood, always free shipping. They said there's absolutely emphatically no additional fee beyond that $150. You're never going to see any kind of invoice with additional charges on there. And he said when you're ready for something to be taken off out of your facility, you give them a call. They have an entire online interface where you can request it online. They handle the DEA 222 form for you. So, no.
So I think as we move along in drug destruction for expired drugs, we really need to network with this group. And as individuals see what their current plan is, compare it with another one, we may want to have some type of grid to see what these companies offer and the fees associated and how the credits are returned. Some credits are sent to your wholesaler that you see in a credit in an invoice that you get from, say a McKesson. And it's hard to track some of that sometimes. So you really want to know what your real costs are to remove expired drugs from your facility. Is one better than the other? Some of it has a lot of bells and whistles. Maybe we don't need that. Maybe you don't have a lot of expired drugs. After all is said and done, maybe you're small enough where you don't use one of these companies and you just destroy it in there. But we still have to think about expired narcotics and whether the CVS route is still acceptable in New Jersey or not. I don't have that final answer for you. We'll be trying to pursue that and get that word out to everybody. There may be no way out of using a reverse distributor or the pharmacy take-back program that some pharmacies are signing up for. And with that, they would send you the 222 form. So I think that's one area that is not resolved yet. This is a topic that came up recently for me. Who knows about the initiative by the FDA to remove unapproved drugs from circulation? You guys did. In 2006, the FDA determined that some drugs never had approval for indications. They were granted approval as a drug prior to 1960. Manufacturers only had approved safety. The drugs were safe to the FDA, and they got approval to make drugs. Neostigmine that we use in the operating rooms today, phenylephrine that we use in the operating rooms today by anesthesia, all in this pre-1960 approval of the drug that's a generic drug made by generic manufacturers that are used daily, but never had an FDA approval for the indication that they're being used. So neostigmine is used to reverse paralyzing agents. We need to have that drug. So along comes this initiative, and I'll give you the example. A company from France applied for a new drug approval from the FDA for neostigmine. Okay, their product is called Bloxavirs. Has anybody get Bloxavirs in yet? Okay. So this is the neostigmine methylsulfide product, approved by the FDA to be used by anesthesia to reverse the neuromuscular blockers. I had an anesthesiologist call me and says, John, we can't get neostigmine. So I called a compounding pharmacy that I deal with. They informed me that this new drug is the only drug that's allowed to be made now. All the generic manufacturers of neostigmine were told by the FDA to cease and desist, or severe fines would be sent because they're making an unapproved drug. So you see what's going to happen here? That vial of neostigmine that you were buying from the generic manufacturers isn't allowed to be made. This company makes Bloxavirs, which is being sold for a 10 ml multi-dose vial for about $80 to $90 a vial. This could cost our industry millions of dollars if this continues. So they also came up with a phenylephrine product. I haven't seen this in the market yet, but soon your generic phenylephrines may result in not being allowed to be made. Have you? Yeah. So this company has now taken 2 generic drugs and created 2 new products approved by the FDA, and these 2 generic drugs that can't be made anymore, and the cost will continue to go up. I just want to put this slide up. This is, the FDA has a list of all drugs in this orange book. If you went to the Google FDA orange book, you can put in a manufacturer's brand name or proprietary name or generic name and see who makes it. So if you put in neostigmine, Bloxavirs would only be allowed to be made in this country. And you can look at some other drugs that in what generic companies. I had to call somebody, want to know is gentamicin still being made in an 80 milligram 2 ml vial. So I went to this website, typed in gentamicin, and 3 or 4 companies still make gentamicin. Okay, you can quickly see if the FDA has stopped production of any other generic drugs that you guys might use. Now the problem I have with Bloxavirs is they approved this as a 10 ml multi-dose vial. It's used in the operating rooms. From the single dose vial. Okay, $90. And what does that mean to your costs? In the past, we could use multi-dose vials as a multi-dose vial. So apparently, the FDA and CMS do not talk to each other. And what we're trying to do is try to somehow have an impact in this, at least nothing else, have the FDA mandate injectable drugs should be manufactured the same as those vials. I thought that was already going to be done, but apparently they just approved this drug as a 10 ml multi-dose vial. And you know, an anesthesiologist can't keep this drug in a med room, and if they need it, not have it on their cart. So therefore, it gets thrown out.
There is a silver lining is that sometime in this fall, there could be a second company coming out with a comparable product. So we might see prices drop sometime in fall of this year. Maybe.
As soon as the second company got approval for their neostigmine, I have the Cabi, Fresenius Cabi, which makes propofol. This company's stock went down 40%. So this company raised their drug price by 200%. So at the meeting last week, we ran into an AMA lobbyist, and we are trying to be in correspondence with this person to see if we can get the AMA, and we're looking at advocacy groups to try to, voice our concerns with this issue with these unapproved drugs that may not be available, only to have come out as a brand name product at much more cost. So this is something just as an FYI that we're following we'll continue to give you more information on critical drugs and shortages. What do we do? What do we do when a drug expires and we can't find it? It's unavailable for a national shortage. It's on back order. What are the steps that everybody takes? Do we keep an expired drug in your building? The Department of Health does not allow you to have any expired medications. Okay. But what if it's a critical drug that you shouldn't do surgery without? First thing you want to do is make sure it's not available from another wholesaler or maybe somewhere else, or we have other forms of maybe getting it. The other thing is it on the FDA shortage list? What other manufacturers are making it? See if anesthesia has any alternatives, if it's an anesthesia drug. Can we get something else in besides this, because we're not able to find it and it's going to go out of date? Ask them if it can be deleted from the formula. Say something on your crash cart that is now expired, that's on a national shortage, and that I think any drug on your crash cart that becomes expired should be posed to anesthesia where the medical director asks, should we continue to carry this? Has anything changed where we may not need this? We've actually made recommendations to eliminate aminophylline, IV aminophylline, even sodium nitroprusside, some things that were always on your crash cart that are not needed. But when it becomes a shortage, the first thing is, are there alternatives to it that we can get in? If not, what do we do? Okay, the drug's expired. Well, you certainly can close and cancel your surgeries if you don't have a critical drug, right? And you don't want to have an expired med, right? If you can't do surgery without that drug that's no longer available, but you only have expired drugs, what do you do? Well, it's up to the owners and the medical staff to say, should we keep that drug if it's expired? Okay? The nurses and administrators cannot say, keep an expired drug in a building. But can a medical director say that? Can the medical staff say that? Okay? They have to be aware that the regulation is being broken. If they know that, they know the consequences of a regulation being broken. If they give you permission to keep that expired drug, what do you do? Well, we felt that if they took ownership of this and they had, this is a sample form that we came up with, and they signed and dated that they say, there's no alternatives, this is a critical drug, I accept responsibility for keeping this drug in the building until the new stuff becomes available, then that would be on file if the state surveyor came in. You still might get fined, you still might get closed for an expired drug, but that's the doctor's decision now. That's the medical staff's decision, not yours. Okay? What I don't want to see is a vial of vasopressin on the crash cart that expired 9 months ago. And when you ask the nurse, they say, oh, we couldn't get it, so we just left it there. And that snowballs to where mag sulfate just gets left on the cart from December and says, oh, we couldn't get it. So it really can't be your decision, it can't be your nurse's decision, it can't be the administrator's decision. If a drug's expired, it can't be in your building. But if a drug's expired and there's no alternatives and your medical director says, we need that here to do surgery, then this form comes out or some type of document comes out that says, okay, you signed date and you give us permission to keep that drug in your building. The intent of this, and this is what I have to stress, there's no one that's allowing you to keep that expired drug in the building, okay? But if that medical director or that medical board or the owners of that facility, you'll have to say we're going to close because we're out of mag sulfate and it's on our formulary. They may say, no, just delete it. But if they say it's a drug that I have to reverse something, say intralipid's expired and there's no intralipid in the country. Now, we would get to that before that problem occurred. We borrow some from somebody, we call another center, we put out a newsletter and we say, get you 2 bags of intralipids because yours expired and we can't do surgery without that. So no regulation, she's absolutely right. They're not allowing you to keep an expired drug in your building. But if your medical director says this is what I want and signs it, it's not on you. You don't own that decision. The state's going to say that's illegal. You can't do it. You know, you're going to get cited. It's a $20,000 fine. And I think building a nice relationship with other centers, with a hospital, if you're not on bad terms with that hospital, that is when that comes in handy. I have a lot of centers that are affiliated with a hospital, and they will let them get those couple bags of intravenous or a couple vials of mag sulfate. This is something that, if it's either closed, or your medical director says stay open and keep that expired drug because we know it's coming in next week, or the shortage is going to be off in a month, it's still 95% potent when it gets to the expiration date. It's not harmful. It's just against the law in this country to have that drug. And when you respond to a surveyor, explain it correctly. Of course, we're not going to have an expired drug in the building. That is what we will not. So this gets rolled out 2 months ahead of time. That the nurse buyer or the manager or the administrator goes to the medical director and says, hey, we're anticipating a shortage. Our current supply is going to expire next month. What do you want to do? We're going to start to call people now, but if we get to the last day of the month when it expires, what do you want us to do? Or is there an alternative? Can we get something else in? Should we just delete it? Should we keep it expired if we get to the last day of the month and we still haven't found any? And you still keep trying to find it. A lot of people put up a little dry erase board in a central area, and they update, drugs that are on shortage, updating it weekly to say, anticipate a shortage, be careful how you're using Toradol. Even if you got Toradol in a different strength, that's a good place to put the dry erase. Caution, new strength Toradol in because the other one's on national backorder, those kinds of things. And you're absolutely right. Build that relationship with that hospital, where in the nick of time you can get something that you weren't able to find somewhere else. Okay. Shopping for a compounder. There are 2 types today in the industry that can compound drugs. The one we always had was a 503A. They're not registered by the FDA. A new one President Obama launched a couple of years ago was an FDA-registered compounder. They require much more intensive guidelines on how they make. They're inspected by the FDA. They can issue bulk higher amounts of products to your facility, and that list can be found on the FDA website. It tells you when they applied to be an FDA-registered compounder. Have the FDA visit them yet? What was did they receive a warning letter? Did they correct the warnings? So it's not just to pick one off the FDA 503B list of registered compounders, is to also make sure the FDA visited them, they corrected any deficiencies. These 503Bs are inspected just like a Hospira or a manufacturer that manufactures brand name drugs. Okay, Hospira had more drug recalls than anybody in the world last year, and so I think that this industry needed that. This industry needed to go, these are your community pharmacy with an IV hood that can make a prescription from a doctor for a patient for that individual patient. They've evolved into helping ASCs with shortages, and I think we run the risks of maybe issues there. Both are being sent out for testing, but I think that this is not inspected by the FDA. This is not the FDA visiting, because the New England compounding fiasco was a 503A facility, so the FDA is not visiting them. If you ever want to know more about this industry, please give us a call. We go out and visit facilities. I've seen some FDA-registered facilities. I've seen some of these 503A. I'm going to go see somebody after the meeting today. We're going to do an unannounced visit, knock on the door, ask to be able to see their compounding pharmacy, because that's what you also want to be able to do, is their doors should be open for us and not have to call and plan for a visit. I visited a facility a couple months ago for my eye centers down in Will's Eye, to let them see the facilities. There is a big difference in the manufacturing of these two facilities, of these differences here. So just some recommendations on what to look for when you're shopping for a compounder. I'd like to be able to speak to the pharmacist at the compounding pharmacy, be able to have that information from the pharmacist. Some of these will have a salesperson. Have you visited it? Has anybody visited? Are they 503B? Have they been inspected by the FDA? And all of these steps you can use to, determine whether you want to go forward with that. There's a need for these in our industry. It really helps with some of these things that you're not allowed to make on site anymore. A lot of my eye centers use the pre-filled eye drops that are handy. Some of these things could be cost savings like our pain centers use Omnipay. They're single dose vials. If we can get a smaller size Omnipay, get a better price. Some of these 503B facilities repackage Omnipay, and we're saving some serious money with this service. Benchmarking, just to show you the studies we've done. Who does endoscopies? Endoscopies here. So you can see it's really shifted to propofol primarily. We still have some individuals that are using fentanyl. This is our endoscopy and colonoscopy percentage. And then who's using Versed? Ketamine's coming back. Anybody using ketamine? Any other ologists using ketamine? Okay. That's something that, this gives you an idea of, how the practice is happening out there. Here's our average doses and then max doses for the propofols. Will they get all these slides too? Mm-hmm. Okay. So you can compare yourselves. If you weren't part of the benchmarking, you can see where you stand. It might be a good thing to take a look at it. Average fentanyl doses for setting ketamine. Ketamine is something that I've been following on our chart reviews. Because for this type of procedure, you want to stay about 20 milligram. If you start to see 50 milligram doses for ketamine, I would question the anesthesia practice. I don't think for endoscopy, colonoscopy, ketamine needs to be that high. Because ketamine has some side effects that you don't want to have in those patients. But at the lower dose, it does have some benefit. This was our cost data. This happened at the end of last year. How many people are part of a buying group? I guess everybody in the room is part of a buying group, right? Who do you guys use? HPG. Okay. Still, some people don't partake in a buying group, which really is something that we're trying to make sure everybody realizes the benefit. Who uses a compounder? These are the number of, pretty much down the middle, no to yes. Who added Ofermet to formulary? Ofermet is IV Tylenol. Yeah, added it, took it off. IV Tylenol, that's IV Tylenol. You know, the cost when it came out was about $13 a vial, 1,000 milligram. And a new company bought this company that made it for $1.3 billion, and he immediately charged $38 a vial. So I don't see a real great benefit from it yet. Time will tell. If the nice multimodal pain management is very important today, so that we don't give too many narcotics, and we have different forms of pain for the patient, so that it hits different receptors. But it's dropped off. Anybody ever order or approve Calvalor? That is IV Motrin. Okay, because of.
It was available and they wanted to try to see if it was better than the Ofermet.
And also, that is very similar to Toradol. Same class of drug, say. So you want to really look at the benefits of that versus your Toradol product that is much cheaper. You know, when you look at outcomes, is there any outcomes differences in the new products versus the products we've been using for years? Outcomes is a really important indicator of whether we should switch to a new medication. Sometimes the marketers just promote it, and it's when you look at the outcome of the studies, it's not as significant. Exparel. Anybody using Exparel? Seems to be the buzzword in the industry today. It just got shot down by the FDA last month. And one anesthesia was looking for an approval for spine, or no, for blocks. Anesthesia was all hyped up about this. Oh yeah, they're going to approve it next March, and the FDA shot it down. So the only indication for Exparel is bunionectomy, hemorrhoidectomy. I know we all use it in joints and spine, and it's all off-label. But off-label's okay, as long as we have literature to document its use in that indication. If your doctor wants to use a medication that is not, it's off-label, and there's no documentation of being used that way, you should prevent that doctor from using that drug that way. We research a lot of calls about a doctor wanting to use a medication in a certain type of procedure that's off-label, and we sometimes will ask the doctor, give us that article, what study did you use that, where else are you using it? And we do the research for the facility before we allow an off-label use of a drug. Now, Exparel is used in joint replacements, is used in spines, and we approve that because it's being used out there that way. But if your doctor wanted to use it for wrist surgery, which a doctor wanted to at one of our centers, we held off. We didn't let them use it for wrist. And we waited to see if there was a study somewhere in this country that has physicians using it and say, what would be the dose? You know, how do we use it? So, you know, safety is really an important thing when you're looking at these new drugs for approval. I'd rather you call the pharmacist and say, hey, Dr. So-and-so wants this drug, and get the correspondence going and the discussion going, because that safety part is something maybe the surgeon, you know, doesn't have. He just wants to use it. We're going to be careful. Count propofol. It's still a non-controlled substance. It has to be locked, but it doesn't have to be counted. Some centers are counting it in their main cabinet just so they know there's no diversion going on. And when propofol was short, we didn't want anybody walking out to the next facility tomorrow with 20 vials. So that's why some people were still counting it. Does anybody count it? Does your anesthesia waste?
No, we don't do the waste, but what we do is assign it to the OR, assign back into the main storage.
You do waste them? Well, you're already ahead of the game. When it happens, you won't have that big learning curve, which we're going to get all kind of resistance from anesthesia when we have to count it and waste it. But in your main cabinet, I think when you issue the anesthesia card, sign out then for main cabinet and let them go. It shouldn't be a free-for-all. This was something mandatory flu vaccine. This again was last year. Is the flu vaccine mandatory for everybody now? It is mandatory. Okay. Vaccination, right. You can see last year still didn't make it mandatory. Very few had it mandatory. This was in 2014. So if we did this benchmark today, we'd probably be at 90, yes. Employee drug screenings on hire. We do have some people that do screenings. Look at this. Of the people we questioned, that was done. And then drug screenings at random. That was interesting too. I didn't think it would be that high on yes. Something to think about as a system, and what your legal stances are, and what you think you should do with that. But that was the benchmarking from 2014. This was called. Well, you can take this back, take a look at the slide. I'm going to not spend time, but we looked at how much people were paying on propofol, Omnipate, and drugs used in the OR. Average cost. How much people were paying? Look at it. Somebody was paying, up to $8 a vial for propofol. Up to $62 for Omnipate. Now we can get Omnipate repackaged by an FDA compounder for about $15 a vial, and that's per patient. So if you do pain, how many pain injections do you do a year? Say you do 1,000 injections a year. That costs you each vial $62,000. If you went with this repackaged Omnipate, $15,000. You'd immediately save $47,000. Thank you. That's what I looked at you. Right. We just put that down in Rockford Orthopedics in Philadelphia. They're going to save $40,000 with a repackaged Omnipate, which. And this changes, so, see the fluctuation in prices here for this one drug? Some people are paying $8 a vial.
Question, how about ICU 200M?
I don't have anybody repackaging that I know yet.
I know about using it. It's a lot cheaper than the Omnipate.
Well, check with your pain docs.
Saving $10,000 a year by converting over from Omnipate to ICU. I sent out to all my pain doctors. Nobody said anything back, so now I'm buying it.
Good. Yeah. Well, that's a big competition with the ICUs and the Omnipate. They all do the same thing. Zofran, price differences, fentanyl, and right on down the line. So take a look at that. Take it back to your place. Buying group's doing you a good job. And also check your invoices. Make sure your wholesalers entered the right contract price in. Don't start me on Glyco. So in 15, the two studies we're preparing, and we're already in the process of doing our cataract centers. The data collection closes at the end of the month. If you haven't submitted the paperwork to be part of the cataract center benchmarking, talk to Brittany, because I think it's really going to be giving you some good data to compare yourselves with other cataract centers. What drugs are used, eye drops, and different things that happen with our cataract surgeries. We've compiled this data collection sheet so that we can put it in a format like we did last year. Pain management for the second half of the year. Our centers that do pain injections, we're going to also do chart reviews and look at drugs and costs and complications of whatever happens out there in those two big categories of facilities we cover. We're always looking for ideas for benchmarking. We like this area because we have a large number of centers that we could reach out to, and those centers do want to see how they compare with others. So let us know if you have other ideas.
Thank you for watching this video. We will continue to provide the most up-to-date pharmacy news and information as it becomes available. If you would like to receive our newsletter, please email me, Brittany Lodato, at the email address shown here. For access to other videos by JDJ Consulting, visit our website at www.jdjconsulting.net or visit our YouTube channel, JDJ Consulting LLC. John and I are always happy to answer questions, so please feel free to call or email us at any time. Again, thank you for watching.